I think this is about where we left off with the classroom recording, and that was with the analysis of the frontal view of the ribs. Remember, you can shoot the ribs either AP or PA, and the difference and the selection of whether you shoot AP or PA is going to be according to where the patient's pain is. So if the patient is complaining of pain on their anterior side, indicating possible anterior rib fractures, you would shoot PA. And then if they are complaining of pain in their back, you would shoot AP ribs. Remember also that we're going to do two views for that frontal projection, be it AP or PA. We're going to do one view to show the upper portion of the ribs and one view to show the lower portion. So looking through the analysis, what we want to see is proper collimation. We want to see about 9 ribs. The number of ribs that you're going to be able to visualize is going to be according to the patient and their ability to take in a breath. If they have broken ribs, they may have a difficult time getting a good full breath in. Also, remember too that body habitus can play a part in that too. So what we're going to see is as many ribs as possible. We're going to take one view on deep inhalation, and then one view on that's for the upper ribs, and for the lower ribs, we're going to take an exposure on exhalation. So what you should see is this. So from this, we can kind of gather a number of different things. So you can count the ribs if you want to, but what we want to see in ribs and bony thorax in general is high contrast. And we do see it here, but we do see also in these ribs in the lower portion, they're kind of burnt out a little bit. And I think that's probably because these are old images from screen film radiography. Your computer algorithm should give you the dynamic range so that you could better see those ribs. But what you also might notice or might not notice is the lung markings. You don't see the lung markings at all on this. So one of two things. We've got one of two things here. We either have a phantom, like what we use in our lab, positioning pixie, which tend to not have well-defined lung markings, or they used what I would refer to as a limited breathing technique. So with that, what they would do, if you remember on the sternum or breathing technique, we used maybe 3 seconds to try to blur out not just the lung markings, but the ribs themselves. Obviously, we don't want to blur the ribs out here. So we would do possibly a limited breathing technique. And what you would have there is possibly as much as a half-second exposure. And what you would do is have the patient take in a big, deep breath and slowly start to exhale. And as soon as they start that exhalation, you make your exposure. That moves the lung markings enough to slightly blur them while not blurring the ribs. So you want to be able to visualize the ribs. So you wouldn't want to use that 3-second exposure. And that's not something that shows up in textbooks, but you'll see technologists sometimes use that if they are shooting ribs. So you can see that you can't see all of the ribs very well on this, and that is because of the density difference. The patient's density is so much higher in the abdominal cavity than what it is in the thoracic. So we're going to shoot 2 sets of ribs, one AP above, one AP below. So again, you can count those out if you want to, but on the one for the lower ribs, what we'll want to do is position somewhere around the iliac crest, maybe slightly above the iliac crest. Notice the difference between the inferior portion of the 12th rib and the iliac crest is not all that far. So you're not going to want to go 3 inches above that, because you would run into danger of possibly not including the lower portion of that rib. So you'd want to go at the iliac crest, possibly slightly above it, with the bottom of your image receptor. On this exposure, you would want to make your exposure at the end of exhalation. So above the diaphragm, position kind of like a chest x-ray, shoot with lower KVP on deep inhalation. And then for the lower, you would position more like an upright abdomen and shoot on full exhalation. And then in that way, you've kind of got a composite so that you can see all of the ribs. If the diaphragm on the above is going right across, you don't see all of D10 here, or this 10th rib. But if we go back down here, we've got 12, 11, 10, probably not the same patient, but you can kind of get the point here. You can, between the two, you can see the entire rib. So where ribs get confusing, probably the most confusing part of the bony thorax is on the oblique of the ribs. Again, which oblique we're going to utilize is going to be dependent on where the patient's pain is. So we shoot at AP or PA, doesn't really matter, but where we're going to see the ribs the way we want to see them is going to change between AP and PA. Remember, everything that you shoot AP, you can shoot PA and vice versa. It's just that everything reverses. So what we're going to do is a 45-degree oblique, and I'm just going to cover the one, but I'm going to explain the difference and demonstrate the difference in what you're going to see. I'm doing this from my office, so I don't have a skeleton, so what I'm going to use is my hands to demonstrate what I need to demonstrate. So our ribs, unlike the frontal view, on our oblique of the ribs, we're only going to shoot one. We're not going to shoot one for above and one for below the diaphragm. We're just going to shoot for where the pain is. So if the patient's pain is higher in the thoracic cavity, we're just going to shoot one on inhalation. If it's lower in the thoracic cavity, we're going to shoot one oblique on exhalation. So AP oblique would be, again, if your posterior ribs were the side of interest. PA obliques would be if the anterior ribs were. So just get the arms out of the way, 45-degree oblique, make sure you use your markers, collimate in, and it doesn't matter if you don't include all of the unaffected lung, and I'll show you why here in just a second. Let me get out of that, go here, and bring the camera up. So I don't have a skeleton in my office, so what I'm going to have to use is I'm going to have to use my hands to demonstrate what's happening with ribs as we oblique the patient. So I'm going to use this is my spine. So this is O'Keefe's. O'Keefe's is a great hand lotion. I'm not getting sponsored for this. It's just for your information. But it's a great hand lotion. You wash your hands a lot. You're probably starting to dry out because it's turned cold. So keep some of this in your locker at clinicals. It's great. It's the only thing that I've found that once my fingers, the skin of my hand starts to crack, that will actually reverse that. So it's great stuff, great stuff. So the O'Keefe's is going to be my spine, and I'm going to try to do this. You got to be real careful because it has a tendency to want to come out. So the O'Keefe's is a spine, and my fingers are the ribs. So the ribs are curved, but they don't come all the way around in front, right? So we talked about that. Your anterior ribs are limited, and the costal cartilage is what actually connects the ribs to the sternum. So we've got posterior ribs go all the way back to the spine, the O'Keefe's, but your anterior ribs stop somewhere out here. Now, imagine that you're the X-ray tube and I am the image receptor. So if you're the X-ray tube and I'm the image receptor, we're shooting at AP, right? This is anterior posterior projection. As I oblique into an LPO, so I'm rotating towards my left-hand side. My left-hand side is down. Look what happens with my fingers that are furthest away from the image receptor. As I oblique up, they become projected on top of themselves more and over the spine, but the side that's closest to the image receptor, they open up, right? So they appear elongated. They're not really elongated, but they appear elongated because you're used to looking at them like this. So on your AP, you're going to, what your side of interest is going to be the side closest to the image receptor. So the elevated side, all the ribs close up. and the side closest to the image receptor, the downside, so to speak, is open so that you can see the ribs. So now if we have a fracture in the axillary portion of the ribs, that's basically the lateral side of the thoracic cavity, then you're going to be able to see those fractures a whole lot easier, right? So now I'm going to try to do this, and I can't see very well. All right, so in PA projection then, as an oblique, and what I'm going to see is that the side closest to the image receptor, now the window is the image receptor, the side that's closest to the image receptor gets projected onto the spine and onto the ribs themselves, whereas the side that's furthest away is going to open up. So what we see then is on PA projection, we see the elevated side, or the side up, is the side of interest. So if we're looking for anterior ribs on the oblique, then according to the textbook, what we would do is we would shoot PA obliques, and we would see the elevated side. You might be thinking that because it's elevated side, we're going to lose some sharpness of recorded detail, and you're not inaccurate. If you're shooting for AP ribs on the obliques, or I'm sorry, if you're shooting for posterior ribs on the obliques, you're going to shoot AP. That's going to put the side of interest closest to the image receptor. My personal opinion is that on the obliques, you should always shoot AP. And the reason for that is primarily what we're looking for on the obliques is the axillary portion. And as we rotate up, it puts the axillary portion directly, really close to the image receptor, and decreases our unsharpness, increases sharpness of recorded detail by decreasing the OID. So that's just critical thinking. But according to the textbook, if you have anterior rib fractures, potential anterior rib fractures, even the obliques, you're going to shoot PA projection. So your clinical versus your classroom understanding is potentially a little bit different. So let me click back over to the other screen and show you what you're going to see on your obliques. Positioning of the image receptor, again, is always going to be 1.5 inches above the shoulders, because we're only looking for the ribs on the side, on just one side. Then we can use the image receptor with collimated field lengthwise instead of using a massive collimated field. And that is because only one side is going to show up very well. So this is an oblique of the ribs. So what we're looking at here, this is right. So this is, if this is AP, that's a RPO projection, right? And these ribs over here just don't matter, really, fundamentally, on this particular image. But we've got an RPO position, position, AP projection, and look at the difference in the ribs and how long they look. So primarily what we're going to be seeing is posterior ribs, and then also the axillary portion of the ribs as well. Primarily what the obliques for is the axillary portion of the ribs. All right. So the things that we're going to be looking for in bony thorax, primary thing that we're going to be looking for are going to be bony thorax injuries. The bony thorax injuries we're going to be looking for primarily broken ribs. And the broken ribs they're painful for the patient, but and they can put plates and screws on ribs to fix them if they need to. But really the dangerous thing is what's going on underneath the surface. So what's going on with the patient? Do they have a pneumothorax? If they have pneumothorax, then their lung capacity decreases. With a pneumothorax, what you may get is a shift in the mediastinum. With a shift in the mediastinum, what you get is what we refer to as a tension pneumothorax, and that occurs because both of your lungs, the pleural space, should have a negative pressure in it, and that's what keeps the lungs inflated. So it's got no negative pressure in it unless you've got a pneumothorax. Now you got a positive pressure that can push the mediastinum towards the opposite side. And if that happens and it collapses the opposite lung, then you've got a real problem. That's what we refer to as a tension pneumothorax. If the patient has multiple rib fractures, that's what we refer to as a flailed chest. A flailed chest, the issue with a flailed chest, let me get back over to the camera, demonstrate this. The issue with a flailed chest is that whenever we breathe, our thoracic cavity, our ribs lift and separate. They provide rigidity so that whenever the diaphragm drops, it creates that vacuum, and we've got those rigid lungs. But whenever we have fractures, what happens is as the diaphragm drops, if we have multiple rib fractures, then those rib fractures, the fragments can kind of go inward. So instead of creating that negative pressure whenever the diaphragm drops, what happens is diaphragm drops, it creates that suction, but the suction in turn pulls the lung in. There's no real exchange of air there. That's a very dangerous situation for the patient to be in. If they have a flailed chest on one side, then they just can't exchange air on that side. If they have bilateral flailed chest, then they can't exchange air at all. In those cases, the only way that the patient's going to be able to breathe, is by putting an intubation tube into the patient and breathing for them. So flailed chests are very, very dangerous. So we got that. And then if our pneumothorax, because of the rib fractures, if the air that's in the lungs happens to get out of the lungs and into the tissue, then we have what we refer to as subcutaneous emphysema. That's free air in the tissue outside of the bony thorax. Now, this PowerPoint presentation is not the same one that's in Canvas. The one that's in Canvas, I added more pictures to it, more images of x-rays to it. So you can see some of the things that I'm referencing here a little bit better, but just kind of running through this. This is a tension pneumothorax. You can kind of see the shift to the mediastinum right here. That's just a bad situation for the patient. This lung is completely collapsed. It's pushing the mediastinum that way. You see how dense the lung tissue looks up here. That's because you just can't get it inflated. So what they would do for that is insert a chest tube, hook the chest tube up to suction, and it would reinflate that lung and, bring the mediastinum back to midline, and the patient would be in much better shape. So multiple rib fractures, flailed chest, you see fractures here, 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 here. They're just all over the place. So they put plates and screws in there to strengthen that. Otherwise, the patient would have to be on a ventilator for a really long time for all of those rib fractures to heal up. So this flailed chest. And a sternal fracture can be very, very painful. I don't know if you've ever been hit in the sternum very hard, but it's kind of like getting hit on top of the head with something. It hurts disproportional to the amount of trauma that it takes. So somebody thumps you into the sternum pretty hard, and they don't have to break your sternum, but your sternum will hurt for a while. So sternum is really tender, and again, there's a lot of positional pain with sternal fractures. So try to move the patient as little as possible. Try to not to have the patient bending over, especially forward. The sternal fracture is just really unbearable. So this finishes up bony thorax. I hope you find this to be helpful to you for the final exam next week. I hope you have a very happy Thanksgiving. I hope you eat a lot. You get some rest, and we'll see y'all a week from Monday.